Hi everyone and very good evening. Myself Dr. Bharat VD, Pharmacology faculty DBMCI and eGurukul. So let me begin this session. I hope the audio video is fine. Let me bring back the mic closer. So yes, I hope the audio video is fine. Just check with that. So I could see your live chats. Okay, so there are certain queries asked by the students. So let me try answering that. Maybe they are simple, but let us take up that queries. The question asked is, can we combine verapamil plus metaprolol? Yes or no is a query. Now remember, verapamil is a non-dihydropyrin and metaprolol is a beta blocker. So both will act on the heart and they can decrease heart rate. This will also decrease heart rate and this will also decrease the conduction. Same thing here. And also it decreases force of contraction and same thing here. So the combination will suppress the heart. So this combination is irrational and should not be combined because patient may have severe bradycardia and conduction, that is AV block can occur. Yes. The next query that we got from the students is the opioid. Sir, what we use for opioid relapse cases? Now, what do you mean by relapse? Now, a patient is already an addict to the opioids. We have de-addicted the patient. Again, he has a tendency to get addicted to opioids. For opioid relapse, the drug used is oral naltrexone. So patient wants to take the opioid again and he has a tendency to that. Suppose this is the opioid receptor and we have given a naltrexone. The naltrexone will sit here and if he consumes opioids like morphine or he takes heroin, he will not have the effects of opioid, that is he will not have euphoria or the kick and he will not abuse it again because the receptors are already blocked. So the drug that is used is oral naltrexone, right? So please comment on that. Now, another important query that has been asked is, what is the drug of choice for MRSA? Now, methicillin staph aureus, the drug of choice is vancomycin. So what we can use is vancomycin. Suppose a patient is having VRSA, the preferred first-line drug is daptomycin. Suppose the patient develops VRSA pneumonia, so then the drug will be linezolid. Now, why we cannot use daptomycin in pneumonia? Because it is inactivated by the surfactant of the lung. Remember, whatever drugs I am marking in green, vancomycin, daptomycin, linezolid, these are only effective for gram-positive bacteria only. That means they are not useful in gram-negative. Another important thing is, what is the drug of choice for carriers of MRSA? Now, carriers of MRSA, the drug of choice is mupirocin ointment. It is mainly for nasal carriers. If that is not there in the option, then only you can go with another drug, vasopressin, that is the ointment that can be used. Yes, so come up with your queries. Any new queries? Yes, Fuzzy Khan, Car, any other queries? Yes. Now, another query that is being asked is, in anti-tubercular drugs which are intracellular and extracellular, first-line anti-TB drugs, which act on intracellular and which act on extracellular. So let me write HRZE and yes, that is streptomycin is considered first line reserve drug. So isoniazid can act on both, rifampicin can act on both, and pyrazinamide acts on intracellular, and it is very much effective in acidic pH of the acidic pH, that is the environment. Ethambutol, again, it's intra and extracellular. This is the controversy. Most of them will ask us whether it is intra or extra. It is clearly given it is both, and streptomycin is mainly in extracellular, plus it is effective in alkaline pH, most effective in alkaline pH, right? Yes. Then after this there is another query, that is, when you are using an antidepressant, there is something called discontinuation syndrome. Discontinuation syndrome, is it seen with SSRI? Now, if SSRIs are used for a very long time and suddenly discontinued, patient will go for this discontinuation syndrome. Is it seen with fluoxetine? Now, this occurs when the drug is not working and when you suddenly stop. Fluoxetine doesn't have this problem because fluoxetine is longest acting SSRI which can work for 7 days. It is not seen with fluoxetine. So it is seen with drugs which are shorter acting, such as fluoxamine, then sertraline, like that drugs. And SNRI, even venlafaxine, can produce this discontinuation syndrome. Yes. Right. So very good queries. Then another query is, what are the GP2B3 antagonists? Do you know that? GP2B3 antagonist. The name is abiciximab. And we have tirofiban. And one more is eptifibrate. All are given parental drugs. Peptide. Now, in all these things, which is safe in renal failure is a commonly asked query by the students. Remember, abiciximab is the one which is safe in renal failure. Without any dose modification, you have to use it. Now, let me ask in this YouTube session, what is a DP4 inhibitor which is safe in renal failure, or it doesn't require any dose reduction in renal failure? No dose reduction. Can you answer that? What is the DP4 inhibitor which is used without any dose reduction in renal failure? Yes, come on. Okay. Then moving on to the another aspect. Another important query which I always get from the student is, now they are also asking that SSRI are used for chronic anxiety. It is used for chronic anxiety. So the query is, sir, SSRI themselves cause as an adverse effect of anxiety. SSRIs can cause anxiety. Then why are they used for chronic anxiety? Now remember, whenever we use SSRIs, this is the synapse. And SSRIs will not allow the serotonin to be going back, so 5-HT will increase in the synapse. So that will act on the receptor postsynaptically and can cause anxiety. So serotonin can cause anxiety. Now when we use SSRIs, the SSRIs will be stimulating initially and anxiety will occur. So that is why when you treat chronic anxiety, SSRI should always be combined with a benzodiazepine. So what happens? Benzodiazepines will combat the anxiety which occurs in the initial days. Now when we use SSRIs for long periods, for example 2-3 months, then the receptor will undergo desensitization and they will undergo downregulation. So the anxiety decreases because of long-term effect. After 2 to 3 months, you stop benzodiazepine. You may ask a query, sir, why don't we continue with benzodiazepine only? Remember, the problem with benzodiazepines are If you use benzodiazepine for a long time, number one, they are sedatives. Morning also patient will sleep. Second, they develop tolerance and patient will have dependence problem with that. So that is not dependence, abuse potential is not there with SSRI. SSRI in fact cause insomnia. Yes, that is the point. So guys, I had asked you a query, DB4 inhibitor safe in renal failure. The drug which is safe in renal failure is linagliptin. Mainly it is linagliptin because it undergoes bile elimination and enterohepatic recycling. Is there any relationship between isoniazid and paracetamol? No relation, not much. Safe in renal failure is linagliptin. Yeah, just a minute. So is there any update in drug of choice? Hyperprolactin in pregnancy, earlier it was bromo and now it has changed to cabergoline. Now cabergoline and bromocriptine both have the same problem. Remember, ergot's adverse effect by this mnemonic EGF. So ergot can produce G for gangrene and F for fibrosis. So both are ergot derivative, bromocriptine and cabergoline. So if both are in the option, I suggest you to go for cabergoline because it is a longer active derivative compared to bromocriptine. So that will be the best one as you asked, Mukul. Yes. Now another important question is, what is the antidote for beta blocker toxicity? Antidote for beta blocker toxicity. So can you answer this? Beta blocker toxicity, the antidote is called glucagon. Why glucagon is the antidote? Now whenever there is beta blocker toxicity, it acts on beta receptor and decreases the heart rate, conduction, and it decreases force of contraction. So this is what happens in overdose of beta blocker. Now glucagon is having a receptor, that is G protein coupled receptor in the heart. So it's a different receptor on which it acts and it counteracts all the effect. Heart rate is increased, force of contraction is increased, and conduction is increased. So that is why for beta blocker toxicity, the antidote is glucagon. Can you use atropine? Yes, you can use atropine also, but it is not the antidote because atropine can only do these things. It can only increase the heart rate and conduction, but atropine cannot increase the force of contraction. That's the only point. Yes. In class of tetracycline, which drug has highest viability? So highest viability is seen with minocycline. Minocycline has highest, followed by doxy, and the least is with tetracyclines. Least with tetracycline. So minocycline has very good viability. Why thiazides are used in treatment of peripheral diabetes insipidus? Yes, Sarshita Reddy, very good question. Now there is a theory. So thiazides, as we know, are diuretics. Thiazides are diuretics. Meaning of diuretic is which increases sodium and water excretion in urine. So they will cause sodium and water excretion in urine. So they are called thiazide diuretics. But we are using thiazide diuretics in peripheral diabetes insipidus. We are using in peripheral diabetes insipidus. What is diabetes insipidus? There is increase in urine, that is called polyuria. So already urine is very much in diabetes insipidus, and thiazides, what do? They increase the urine output. So peripheral diabetes, already there is increase in urine, then why are we using thiazides? Now remember, thiazides in this condition has a paradoxical action. Paradoxical means the action which has to be produced is not seen, the opposite action is seen. Paradoxical effect. Now in paradoxical effect, it has known to decrease the urine. How does it do that? Now there is a theory proposed for that. Suppose there is a nephron. This is the proximal convolutive, and this is the loop of handling, thick and thin, and we have this distal convolutive, the collecting duct, and all those things. Now when I use thiazide diuretics, you know that thiazides are going to work in the early part of DCT, so that will inhibit a pump called sodium chloride symport. So that will lose most of the sodium. So when the sodium is lost, along with that water is lost, that is what we mean by diuresis. But what happens in this condition, particularly diabetes insipidus, there is reabsorption of sodium back into the PCT. So PCT try to conserve that sodium that has been lost, and along with sodium, water will also get reabsorbed. So when the water gets reabsorbed, there is decrease in urine output, and that's why it can treat polyuria that is seen with diabetes insipidus. This is the mechanism proposed for the thiazide diuretic. So it can be used for both central as well as peripheral diabetes insipidus, and that is the paradoxical effect what we see with this drug. I hope Archita you got that. Sir, it was given that as alcohol increases action of cytochrome 2E1 and changes to NABQI, same action by isoniazid. See, isoniazid has multiple action. In some enzymes, it's an enzyme inhibitor. Some enzyme, it's an enzyme stimulator also. So it can also stimulate that enzyme CYP2E1. Sandeep, there was one question comes in FMG this time. Patient is on escitalopram antidepressant, but he still want to jump from building. What is the next line of treatment for this patient? Maybe that will be answered by psychiatric faculty, Sandeep. Maybe there is some other therapies which are asked. So I should get the drug list. So maybe it may be electroconvulsive therapy. So I need to get the option, then only I can tell you the right answers. Okay, so please post any other queries here. So they had asked another query. Now, tardive dyskinesia. What is the treatment for the tardive dyskinesia? So tardive dyskinesia, the treatment is dopamine depleters. Now what happens when you use the typical antipsychotics for years together? This is what happens. Now when I use typical antipsychotic, what do they do? They block the receptor D2. When you block the D2 receptor for a very long time, the receptor number will increase. That is called upregulation, and they will become super sensitive. So some of the dopamine that is released will activate these dopamine receptors, and the patient will have tardive dyskinesia. So for tardive dyskinesia, the culprit is dopamine. We have to use dopamine depleters, for example, VMAT2 inhibitors. So what is the role of VMAT? The role of VMAT is to keep dopamine inside the vesicle. If that is not kept, dopamine is metabolized by the enzyme Marrow. So if I inhibit VMAT, the dopamine is not broken down. I mean, it will be broken down because dopamine is outside, and this will decrease the dopamine, and that will decrease the tardive dyskinesia. The drugs are valbenazine, and one more is called deutetrabenazine. These are the drugs which we use for tardive dyskinesia. Okay. So I'm not getting your queries. Mukul Buria, is clarithromycin a P-glycoprotein inhibitor? Yes. So clarithromycin, it is an inhibitor of P-glycoprotein. So what is the role of P-glycoprotein? Suppose this is the intestine. So to protect harmful chemicals entering in our body, there is a protein called P-glycoprotein which will throw the drug out. For example, digoxin will be thrown out by P-glycoprotein. Suppose if I am using 200 drugs of digoxin, 100 will be thrown out and 100 will enter inside. So it has some capacity. It cannot throw out every drug. So if I use clarithromycin with digoxin, it inhibits the P group protein and more drug enters. So you know that digoxin is narrow therapeutic index and a simple increase in dose can cause toxicity. So clarithromycin should never be combined with digoxin. So that's the point. Hydralazine. So the story of hydralazine, many a times the hydralazine is thought to be only a potassium channel opener. Remember, hydralazine is a nitric oxide donor. It is also having calcium channel blocking property, and also it's a potassium channel opener. So it has multiple actions which will mainly cause artery dilation. So it's a predominantly artery dilator. So by dilating the artery, it can decrease the blood pressure. So which condition do I use hydralazine? Hypertension. It is also used in chronic CHF to decrease mortality in African American population. Sandeep Mitra, there was a question asked in West Bengal University exam. Why loop diuretics and thiazides fail in treatment of patient with hepatic edema? Now let me explain that. Now what is hepatic edema? Hepatic edema is because of liver cirrhosis. So there will be liver cirrhosis, that's why there is hepatic edema. Now in liver cirrhosis, the aldosterone levels will be high. Aldosterone levels will be high. So when the aldosterone levels is high, the sodium and water gets retained, retention occurs, and that's why the patient is having edema. Now in this condition, if you use the thiazide or loop diuretics, they cannot provide the complete sodium and water evacuation because aldosterone is a culprit. So the best drug, the best diuretic is the one which blocks aldosterone. So we have aldosterone receptor blocker, and that is spironolactone. So spironolactone is the one which can oppose the action of aldosterone. The loop thiazide diuretics, they cannot oppose it. So that's why the drug of choice for cirrhotic edema or liver-induced edema is spironolactone. This was the question asked in recent NEET PG exam. So that's the reasoning. Sir, how beta blockers help to reduce infarct size in MI? Very good question. Now, what is MI? It's a myocardial infarction. So what exactly occurs in MI is, now this is the coronary artery, and in MI there is complete blockage of the coronaries. So if this is the heart and that coronary is supplying some part of the heart, now what happens if the heart beats faster? If the heart beats faster, what happens? The supply should also be more. But here in MI, the supply is decreased. And if heart beats more and more, there will be more and more hypoxia and more ischemia, and infarction will increase. So if I use a beta blocker can decrease the heart rate, it can decrease the conduction. Along with that, it can increase the diastolic duration. So that diastolic duration will help to improve the coronary blood flow also, because diastolic is the phase where coronary will supply the heart. So diastolic duration is increased. So then death of tissues will decrease because we are decreasing the demand during MI. And not only that, the beta blockers also can decrease the risk of arrhythmias because they decrease heart rate and conduction. That's why. Sir, for heart, which is correct regimen? Because sir said tenofovir is given nowadays and you taught yes. See, the point is, for the management of HIV, previously we used to have the guidelines, that is NACO guidelines. Still we are using it. Now the WHO guidelines is recommending for the use of the tenofovir plus lamivudine plus dolutegravir. That is, you are using 2 NRTIs plus integrase inhibitor. This is the one which is recommended by the WHO, because the tenofovir, lamivudine, dolutegravir, they have very good efficacy and less adverse effects. But still in India, the NACOR guidelines have not updated that. In that, we are still following tenofovir lamivudine plus efavirenz. This is followed in Indian guidelines and it has not updated. So that is why, remember, if the examiner is asking from NACOR guidelines, it is TLE, that is efavirenz. Now, you may ask a question, why not dolutegravir Indian regimen? Because dolutegravir is costlier. And that is why this TLD regimen in India is only approved during post-exposure prophylaxis. Why it is approved only during post-exposure prophylaxis? Because that is given only for 28 days. So that is not a burden of cost. But this has to be given lifelong. So it depends on the country to country. So if they ask you mechanism of action of hydrolysine, then which one? Remember, mainly it's a nitric oxide donor. You can go with that. Sir, why use digoxin in acute CHF? Now remember, the usage of digoxin in acute CHF is coming down nowadays. We have better drugs for acute CHF. We have drugs which are ionotropes. Number one, you can use dobutamine and dopamine. These are used if that ionotropes are not working. So we have the phosphodiesterase inhibitor, that is ionodilators can be used. Along with that, we use vasodilators which decrease preload and afterload, that is nitrates, that is mainly nitroglycerin, neseritide. Still the patient is not responding, then the last resort will be sodium hydroxide. If it is not responding, then only the digoxin has to be used. Otherwise, the use is obsolete nowadays. Now remember, dobutamine, dopamine, if I give continuous administration, there is a chance of developing tolerance. Even if you continuously use ionodilators, they will develop tolerance. So the last thing what remains will be digoxin. So that's the last resort. So ritonavir is inducer as inhibitor of glycoprotein. Remember, ritonavir and most of the microsomal enzyme inhibitors. So I will give a general idea that most of the microsomal enzyme inhibitors, they are also P-glycoprotein inhibitors. So ritonavir is a microsomal enzyme inhibitor. Typically, it is used as pharmacokinetic booster along with lopinavir. So it is used with lopinavir plus ritonavir. Yes, this is the one. Okay, so any other queries, just put a message to me and I'll be going through that. So another important aspect is lithium. Now lithium, whenever we use lithium cannot work in acute mania. It can be used, but it's not a drug of choice for acute mania because lithium starts working after 2 to 3 weeks. So it has to do neuroadaptation, so it will take 2 to 3 weeks. And lithium has to be done therapeutic drug monitoring because it's a narrow therapeutic index drug. But when you want to measure lithium, first allow the drug to achieve steady state. Now the half-life of lithium is 1 day. Now tell me how many days are required to achieve steady state. I'll be waiting for your answers in the YouTube channel. Now after this, when the patient takes the drug, for example, is taking 9 a.m., can I measure the lithium that time only? No. So the drug has to peak and then it will fall down. The drug will peak around 10 to 12 hours after you take the dose. So the ideal time is 10 to 12 hours post dose. And today I gave lithium, tomorrow I cannot measure. I want lithium to achieve steady state, then only I have to measure it. Yes, then only I have to measure. So remember, the steady state is achieved after 4 to 5 half-life, that is 4 to 5 days. Very good. Levodopa-induced dyskinesia, what is the drug of choice? Levodopa-induced dyskinesia. The drug of choice will be amantadine. So the drug used is amantadine. Okay, yes. So let me take some other queries. Okay, so the query is, which drug is called Mrsa? Mrsa stands for non-allergic and specific serotonergic antagonist, that is called mirtazapine. So mirtazapine is called Mrsa. The advantage of mirtazapine is it can have sedation, it can produce sedation. So patient having depression, insomnia, we can use it. Mirtazapine produces less sexual dysfunction. A very good question. See, estadiphylline is a drug which is used during off episodes. Off episodes, that to prevent that, what we use is estadiphylline. So please understand the meaning of on episode and off episode. On means the drug is in the higher level. So why this occurs? Usually the dopamine has to store in the vesicle and then release. So as the disease progresses, Parkinson's disease, that storage capacity is not there. And the dopamine, when you give as a drug, it will increase. So when the dopamine is increased, patient will be having on phenomenon. That is, patient will have a problem with excessive dopamine, that is dyskinesia. So the drug suddenly will fall from the high level, and off episodes means no dopamine or less dopamine in the brain. So patient will go for off episodes. So suppose the patient immediately goes for off episode, we have a rescue therapy immediately. That is what we give as apomorphine. Apomorphine subcutaneously it is given. So that is to immediately treat the off episode. So off episode means patient will manifest the symptoms of Parkinson's disease, or nowadays in foreign countries we have levodopa, which is available as intranasal. Intranasal is available. But to prevent this, patient should not have this off episode. What is the reason why it is occurring? Because the drug is very short, levodopa is very short thing. So use levodopa sustained release, use levodopa plus carbidopa, use COMT inhibitor. Recently we have come up with a new COMT inhibitor that is called opicapone, and MAO-B inhibitors like selagelin, rasagelin, and now the D2 agonist. These are the one which can prevent off episodes. On means dyskinesia. For that treatment, what we use is amantadine. Right. So I hope you got the point, Mukul. So I hope I told you when to use apomorphine. So it's an emergency, we use it. Why Ramiprilla is used in the treatment of heart failure? Very good question. So let me explain that. Now Ramiprilla, anything with prill, they are ACE inhibitors. Now problem in chronic CHF heart failure is there will be increase in aldosterone. Why there is increase in aldosterone? Because decreased cardiac output to compensate that the RAS pathway gets activated. This aldosterone is the one which is going to cause ventricular remodeling, and it will cause myocardial apoptosis and myocardial fibrosis. So the disease progression, CHF will worsen and the disease will progress. Patient will go for permanent heart failure. So you have to give him new heart or the patient will die. So that is what we call it as mortality. So the generation of aldosterone is from the pathway angiotensin 2, you get from angiotensin 1. So this ACE is the one which generates that. Suppose if I inhibit that ACE, aldosterone will not produce its effect in chronic CHF. So if I block that aldosterone activity, it can decrease mortality. So ACE inhibitors can decrease mortality in chronic CHF. That's why we use them here. So I hope Anirban Dey, you got the answer. So Krishna Singh has asked a question: can metoprolol cause hypoglycemic unawareness if combined with insulin? Obviously, but the risk is lesser. Now please understand, when I write cardioselective beta blocker, meaning, what do you mean by that? The beta 1 is there and beta 2 is there. So this drug will block beta 1 more than beta 2. So metoprolol, if I consider it's a cardioselective beta blocker, the meaning is it blocks more beta 1 and very less beta 2. So that's why the risk of bronchoconstriction, the risk of hypoglycemic unawareness is very less with metoprolol. So that is very less compared to a drug called propranolol. So propranolol produces more hypoglycemic unawareness compared to metoprolol. So metoprolol is safer in case of diabetics, in case of asthma patients, COPD, and peripheral vascular disease patients. That is the meaning of cardioselective beta blockers. So it can also cause, but minimal, but you can use safely in diabetics. So I hope you got the point. Is opicapone a newer drug? Can you please compare it with? See, opicapone is a newer drug which is similar to Coumadin, but there is no specialty, and it can decrease the off episodes. Okay. Does dapagliflozin cause bladder cancer? No. Dapagliflozin, remember, dapagliflozin, anything ending with gliflozin, they are SGLT2 inhibitors. So the problem with SGLT2 inhibitors is, number one, they can cause UTI because you are throwing glucose in the urine. Second problem is genital mycotic infections. Genital mycotic infections are common. But very rare problems are diabetic ketoacidosis can occur. This is euglycemic diabetic ketoacidosis. Then increased risk of fracture. So there is a warning given that increased amputation risk. Particularly this amputation risk is more with a drug called canagliflozin, Cana. So these are the things. And one more rare problem is Fournier's gangrene. So dapagliflozin will not cause any bladder cancer. Bladder cancer risk is more with pioglitazone. Imran Resin, can we use propranolol for migraine? Yes. One of the most commonly used drug for migraine prophylaxis is propranolol. Migraine prophylaxis. The drug name is propranolol. Yes, you can use it. You can use it. Okay. Yes. Yes, guys. Any other queries? So I'll take up some other things. Yes. Okay, so methacholine, the usage has come down. Remember, methacholine main action is on M2 compared to M1 or M3. So its major action is on the heart. So methacholine is used to treat tachycardia because most of the cholinergic drugs will cause bradycardia. So that is taken into advantage and used to treat tachycardia, but that usage has become outdated now. Okay, so the mechanism proposed, how propranolol is used in the management of migraine is propranolol crosses blood-brain barrier, and it is known to decrease the anxiety. It has known to decrease the stress, right? And also it is a vasoconstrictor. So you know that beta will cause vasodilation and beta blocker will cause vasoconstriction. What happens in migraine? There is vasodilation, so they can decrease that vasodilation. It can also decrease anxiety and stress, which are the triggering factor of migraine. That's why we use it. Okay, so these are the points. So another question is, what is the competitive antagonist of GABA at GABA A receptor? So commonly asked question. See, the GABA receptor is a pentameric structure. It has 5 subunits. So alpha, beta, and gamma. So the interface between alpha, beta is the place where the GABA binds. So for this, the agonist is GABA, and one more agonist is mucimol. So these two are agonists for this site. The antagonist for this same site is bicuculin. The name is bicuculin. This is the antagonist for this. So remember, competition means the agonist and antagonist bind to the same site. That is the first thing you have to remember in your mind. Competition means same site. Now, what is non-competitive antagonism? Non-competitive means they are working at different sites. That is the point number 1 you have to remember. Now, the benzodiazepines act at alpha gamma interface. Here, the benzodiazepine act. Now, let me ask you this question. Benzodiazepine and bicuculin, are they competitive or non-competitive antagonists? So please answer that. Are they competitive or non-competitive antagonist? Yes, tedizolid in some cases it has shown to produce peripheral neuropathy, but mainly it is caused by linezolid. So remember, if you are using linezolid for more than 6 weeks, then there is a problem of optic neuritis and it can produce peripheral neuropathy. And linezolid specialty is the drug. It has approximately, if you give oral also, 100% bioavailability. Not 100%, approximately, that's what I told. So which route has 100% bioavailability? It is the IV route. But orally also, if you give, it has 100%. Another drug which you give oral and has 100% bioavailability approximately, an antibiotic is levofloxacin and ofloxacin. They have approximately 100% oral bioavailability. Linezolid, another specialty that is asked in the exam is it's a MAO-B inhibitor. And remember, linezolid doesn't require dose reduction in renal failure. Will linezolid cause bone marrow suppression? Yes, it causes bone marrow suppression. Obviously, linezolid causes bone marrow suppression. It decreases the platelets, thrombocytopenia, which is very common, and it decreases neutrophils. So that's why if the patient is already on anti-cancer therapy, he develops some infection, you should not use linezolid, because anti-cancer drug also decreases the bone marrow. That means they suppress immunity, and linezolid also causes bone marrow suppression. That's why that question was framed in recent exam and asked. Yes, very good. Many have asked very valid questions. Happy with your queries. Good. So they had asked a question, which of the following drug will be used in preventing acute mountain sickness? Remember guys, for acute mountain sickness, to prevent or to treat, The drug of choice is always acetazolamide. Acetazolamide. That is the drug of choice. Along with that, you can add another steroid that is called dexamethasone. They can be used, but the best one is acetazolamide. So in rheumatic heart disease patient with prosthetic heart, when we should shift the patient from warfarin to heparin. So remember, from warfarin to heparin, that is low molecular weight heparin, you have to shift at the end of 36 week. So when the 36 week ends and 37 week begin, that time you have to start. That is, you start from 37th week. That is the answer. Another frequently asked queries are, what is the main aim of phase 1 trial? Now, phase 1 trial is called the human safety trial. The name itself is telling you human safety trial. So what we do in phase 1 is we check whether the drug is safe or not. So the primary aim in phase 1 trial is to find out the safety, whether the drug is safe or not. Because in human phase 1 trial, we involve human healthy volunteers, so they don't have disease only. Then what will you check? You can't check efficacy. What you can check is safety and maximum tolerated dose. That can be found out. And along with that, we check for pharmacokinetics. But the major priority will be for safety, safety, safety. Now, what is the schedule of drug to be sold on the prescription only? That is called Schedule H. So Schedule H will tell us what is the drug which is prescribed by a registered medical practitioner. That is Schedule H. Without any prescription, they are called OTC. Now, what is Schedule X and what is Category X? Category X will give us ABCDX for the teratogenic properties of the drug. Schedule X will give us the drug schedule which is highly psychotropic and narcotic drugs like ketamine, amphetamine, methylphenidate, phencyclidine. What do you understand by Schedule X? The meaning is the drug has to be prescribed in duplicate. One prescription has to be kept by pharmacist up to 2 years. So example is ketamine. Right? So in most of the prescription, it is written as NRX. Now tell me guys, what do you understand by the letter N in the prescription? This is not asked till now. So let me ask you through this YouTube channel, what is that N stands for? See, there is nothing like Manas Datta postprandial hyperglycemia drug of choices. Postprandial hyperglycemia, it depends on patient to patient because diabetes, the treatment varies. Still, if they insist on asking the drug which decreases postprandial blood sugar, even insulin can decrease that. So insulin can decrease PPBS. So the acarbose or miglitol or the oglivose, they can decrease it. And also the meglitinides, rapaglan, antagonist can do that. But to decrease PPBS and FBS, the best is always insulin. That is the one. Another confusion students ask is, what is the drug of choice for pregnant female? Pregnant female, and this pregnant female who has suspected baby with congenital adrenal hyperplasia. So the fetus inside is suspected with congenital adrenal hyperplasia. So then the drug will be dexamethasone. So the drug will be dexamethasone if you suspect the baby is prone for congenital adrenal hyperplasia. Suppose the baby is already born with congenital adrenal hyperplasia, for the baby you have to give hydrocortisone. Why do we give hydrocortisone? Because hydrocortisone has both mineralocorticoid and glucocorticoid, what is 1:1. And dexamethasone, why do we use? Because dexamethasone can cross the placenta very easily and it can suppress that action of the androgens on a female fetus. Okay, so let me take other queries here. So what is the update of drug use for babesiosis is a question. So babesiosis, now the updated treatment guidelines is for if it is mild to moderate or if it is severe cases, whatever case, you remember the treatment is A plus A. What is that A plus A? A is azithromycin and one more drug is atavocone. So these can be used for that. If the patient is not responding, then the next option will be clindamycin plus quinine. Clindamycin plus quinine can be used. So that is the point. Okay, so what is the drug of choice for cutaneous larva migrants? Cutaneous larva migrants, the drug of choice till today also is albendazole. Even for visceral larva migrants, the treatment is albendazole. If albendazole is not there in the option, if they give cutaneous larva migrants, another drug that can be used alternatively is ivermectin. So this is another thing which can be used for this. Manas, the enoxaparin is safe in renal failure? No. Heparin, low molecular weight heparin, they are eliminated in kidney, so you have to reduce the dose of them in renal failure. Rusikesh, but acne treatment according to stages, and that will be dealt in dermatology, because we don't, pharmacology, we don't treat the stages of acne. That's why. Okay. Yes, very good question, Anvesha. Now, guys, migraine, there are two theories proposed for acute attack of migraine. Number one is called vascular theory. Number two is the neurogenic theory. The vascular theory tells that there is extracranial vasodilation. So this is known to produce headache. Neurogenic theory tells that there is neurogenic inflammation, there is increase in calcitonin gene related peptide. So these are the theories what tells us that migraine attacks. So because of this, whenever there is an attack of migraine, we want to use vasoconstrictor and the drug which decreases inflammation in the nerves and the one which decreases nausea vomiting. So all these three are done by triptans, particularly the drug such as sumatriptan. If sumatriptan is not available, you can go with ergots. Ergots will also cause vasoconstriction, but they don't decrease neurogenic inflammation. A very valid question is, why do we use verapamil, which is a vasodilator? Why do we use it? Now, there are theories proposed. The trigger of migraine starts with vasoconstriction followed by vasodilation. So you know that vasodilation is the phase where we get attack. So trigger is here, vasoconstriction. So we want to prevent that vasoconstriction, trigger the decrease the trigger. That's why verapamil is used as prophylaxis, which will prevent the vasoconstriction that can occur here. So that is the theory proposed for verapamil. Krishna Singh, can we use CCBs for diabetic patient? Yes, CCBs can be used in diabetic patients. Yes, but with hypertension, yes, you can use it. But the best ones are ACE inhibitor or ARBs. Why compared to CCBs these are better? Because these AC ARBs, they are known to decrease microalbuminuria. Why? Because most of the diabetics, high glucose can damage the kidneys and albumin will come in the urine. That means kidney damage has occurred. So it will decrease that microalbuminuria. So it will help in diabetes. So the best will be AC or ARB. If that is not there, you can also use CCBs. Now remember, when you analyze an antihypertensive, check whether they cause any metabolic adverse effect. Metabolic adverse effect means, will they cause high increase in glucose, will they increase uric acid, and will they increase lipids? So all these CCBs and ACE inhibitor, no metabolic adverse effect. And CCBs and ACE inhibitors, check whether they cause sexual dysfunction. No, they don't produce any sexual dysfunction. So that's why they are kept under first line therapies. But if you compare with thiazides, thiazides can also cause metabolic adverse effect. But nowadays, when we use low dose of thiazide diuretics, the increase in glucose, increase in uric acid, increase in lipids are very less. Do thiazide cause sexual dysfunction? Yes, they cause erectile dysfunction. What about beta blocker? Yes, beta blocker also produces dyslipidemia and also it produces sexual dysfunction. What about prazosin or a alpha blocker? Alpha blocker, it's very good for dyslipidemia because it can decrease the LDL triglycerides, but it can produce inhibition of ejaculation, sexual dysfunctions there. So this is the comparison I can give to you. So the query is, which drug produces congenital QT aplasia? So congenital QT dysplasia is a problem that is seen with the antithyroid drug, that is carbimazole, and a drug called methimazole. They can produce it. And next question is, which is the longest acting in insulin preparation? Remember, the longest acting insulin preparation is degludec. It is degludec. Right. And most of you will confuse glargine with glulysin. Glulysin. Glargine, remember, is the long-acting insulin and it is a rapid-acting insulin. How do we avoid the confusion? Remember, glargine for large. So it is long-acting. Glulysin, if you remember one, the other will be rapid-acting. That's it. So these are the things how you can understand. The last query of the day, what I will take is, what is the drug of choice for malignant hyperthermia? Malignant hyperthermia, it is a pharmacogenetic abnormality, particularly seen with the succinylcholine or fluorinated general anesthetic halothane. So in some people, the ryanodine receptor 1, which is present in skeletal muscles, are defective. So when the anesthetics are given, they release calcium and that will increase the muscle rigidity, the body temperature will increase, and that is what we mean by malignant hyperthermia. So what is the drug of choice for that? Is the one which blocks the ryanodine receptor, and the drug of choice is dantrolene sodium. Because it blocks the ryanodine receptor, decrease calcium, decrease muscle rigidity, decrease temperature. Same thing, we have something called neural malignant syndrome. This is caused by typical antipsychotics because they block D2. Here also the same problem, ryanodine receptors are active and they release calcium, so muscle rigidity and temperature rise. For this also the drug of choice is dantrolene. But if they ask you the antidote for this, then it's a D2 agonist called bromocriptine. Please remember this point. Only if they ask you antidote, then you should come with bromocriptine. Then only the answer should be bromocriptine. Otherwise, if they ask you first choice, drug of choice, whatever they ask you in the exam, except antidote, the answer would be dantrolene. Okay, so that's it. Okay, so thank you for your queries, and they are beautiful queries to answer, and majority have asked valid questions, and I hope I could solve majority of your queries. And yes, so we'll wait for another 1 or 2 minutes and wait for any other queries. Okay, for further queries, you can join the Telegram group. So there is a Telegram group. You can type Dr. Bharat Clinical Pharmacology. So you can join there and you can post your queries. Or you can approach me with the DBMCI Premier group or in the eGurukul app. So what is applicable for you? Krishna Singh, patient of rheumatoid arthritis started on DMARDs and patient developed blisters and rashes. Obviously, it should be a sulfa drug, that is sulfasalazine, because they can cause skin toxicity like rashes and blisters. Anvesh, the white ipratropium is preferred in COPD than asthma. Now, problem in COPD is COPD mainly affects the larger bronchioles and asthma affect the smaller bronchioles. So asthma, we need to use beta-2 agonist, and COPD, we use the ipratropium bromide, that is called SAMA. That is one reason. Second reason is in COPD, the cholinergic tone is high. And you know that cholinergic drugs can cause bronchoconstriction. So what should I do? I have to block cholinergic tone. And who will do that? Muscarinic antagonist, and that is nothing but ipratropium bromide. That's why they are preferred in COPD. Point number one, COPD will affect the larger bronchioles. We have to dilate it. That is done by ipratropium. Second, in COPD, cholinergic tone is high, so you have to block it, and that is done by ipratropium. That's why it is preferred in COPD more than asthma. Okay. So thank you all. Good night. Take care. So any other queries, I will be happy to answer. You can post in the YouTube also, that I will be answering. Thank you all. Good night. Take care. So all the very best for your upcoming exams. We'll meet up frequently. Thank you all.